Hello, everyone. Thank you for joining us today for another episode of Pearl's monthly lecture series for 2025. For anyone who is new here, Pearl stands for POCUS for Emergency and Acute Care in Resource-Limited Settings. We are a nonprofit organization entirely run by volunteers, and we aim to provide free POCUS training to doctors around the world. Our guest speaker for today is Dr. Tom Heller, zooming in from Germany. Dr. Heller specializes in general internal medicine and infectious diseases and has been working in South Africa and Malawi for 10 years. His special focus lies on aspect of care for patients with advanced HIV disease, tuberculosis co-infection, and other opportunistic diseases. Throughout his career, his interests were ultrasound protocols, and application for resource-limited settings and sonographic diagnosis of infectious diseases. He has taught multiple ultrasound courses in several countries around the world, and today he is here with us and shall present on the use of point-of-care ultrasound in Kaposi, Sarcoma. Without further ado, Dr. Tom Heller, please take it away.
Thank you, Long, for that nice introduction. Thank you for having me again. Yeah, let's the topic of the day. Let me see that I can yeah, no, I can see. Yes, fine. You can see my screen in presenter mode, right?
Absolutely.
Cool. So what we want to talk today is about Kaposi sarcoma, and I hope that those who joined us still may remember that my last talk was about ultrasound in TB, and that's usually where we in Malawi use ultrasound to find signs in advanced HIV disease for disseminated tuberculosis in advanced HIV disease. Because what we see there, I just want to give you a reminder, because that is that somehow leads to the topic of the day. What we usually find in TB in HIV patients with advanced disease, advanced immune suppression, is that they get extrapulmonary TB, and this or disseminated TB, and this extrapulmonary / disseminated TB can manifest itself as pericardial effusions. Then it's TB pericarditis. It can manifest itself as pleural effusions, which is then TB pleuritis, and it can manifest itself in lymph node swellings in the abdomen, which especially in the upper abdomen, which we look for. And then what we found over the years, and it's not unique to TB, but it is quite characteristic for TB, is that the patients have micro abscesses in their spleens, which is in a way a sign of dissemination, like the miliary micro abscesses in the chest X-ray that everybody knows who deals with TB patients. In our setting in Malawi, we in the Lighthouse Clinic, and here up there you see a nice picture of the entrance. We see also a lot of Kaposi sarcoma, and that of course brings in a differential, and that is what triggered us to look at this a little bit more in detail. And I will start now with showing you some slides. For those who are not dealing with Kaposi sarcoma every day, I thought to start with a short introduction in Kaposi sarcoma in general. What is it, and how does it manifest? Then I wanted to look at what can the ultrasound help us, and then finally, if we find the time, I would like to look at some cases, 2-3 clinical cases, just to see how to contextualize it a little bit. So let's start with the history. It's always good to start with history. The KS was one of the early signals of HIV. So it was actually this report in 1981, as you can see in the Morbidity and Mortality Weekly Report from the Center of Disease Control in the US, that reported that there were Kaposi sarcoma, which was a known entity, but it was a rare tumor, and it was suddenly seen in young homosexual men, and together with the pneumocystis pneumonia, which of course today in retrospect we know this was the beginning of the HIV/AIDS pandemic, and it took a couple of years until the virus was isolated and the disease was characterized. But the hallmark, or the finding that was very visible, was Kaposi sarcoma. And in the next, yeah. in a minute you will understand why why it was so visible. So basically, the with the immune suppression that HIV causes, the immune system drops, and so does the cancer surveillance. And in this setting, then some AIDS-defining cancers flourish and become far more frequent. And here you see some of the cancers. So that is Kaposi sarcoma is actually 500-fold increased. And I want to mention that already now. It is caused by a virus, human herpes virus 8 or Kaposi sarcoma herpes virus. Aggressive non-Hodgkin lymphoma, 12 times higher, also caused by viruses. Primary CNS lymphoma, luckily we see it very rarely because it is really correlates with very, very low immunity, basically to the single-digit CD4 cells. How 150 times more frequent. Invasive cervical cancer, only 3 times more frequent, but it is still quite frequent overall because it is also in the general population, a common cancer. And then also the risk of some non-AIDS defining that didn't make it into the definition, but they are also increased, as you can see down here. But it's not all cancers, as you this final note. So breast cancer, prostate cancer, colon cancer, for example, are not increased in HIV positive populations. What happened with the incidence of of cancer overall? And this is data from the Western world, from the Europe and the US. And you can see that there was the AIDS-defining cancers, they were quite high in the HIV population, and then they massively dropped. And why did they drop? Well, obviously, this is the period where antiretroviral therapy, or effective antiretroviral therapy, was rolled out, and that basically did away with with a lot of the severe immune suppression, and thus with a lot of cancers. But still, if we look now more in an African setting, we find that this is data from the Uganda Cancer Institute, that indeed cervical cancer and KS, which and also the non-Hodgkin lymphoma, the 3 of the age-defining cancers, still play a significant role. And in males, that is not visible here, but it is indeed the case that in males patients, Kaposi sarcoma is the most frequent cancer of all. And that is not only so in Uganda, but it is also so in Malawi. And well, why is that so? I mentioned that Kaposi sarcoma herpes virus, also known as human herpes virus 8, is triggering the cancer. So this is the cause, one of the root causes. Obviously, it's not in itself alone, it is not enough. But in combination with the immune suppression, it can lead to the cancer. And as you can see, the seroprevalence rates are particularly high in the Eastern Central African region. It is actually doesn't show very well here, but doesn't show very well here, but it's actually higher here than in South Africa, where we see far less Kaposi sarcomas. How do patients, they are not patients because they're not getting sick, but are they infected? Well, basically, we think that in endemic areas there is a non-sexual spread. So basically horizontal, probably children get already infected. We know that probably by saliva shedding and then touching, and then that's enough for the transmission. It is per se not a very aggressive virus, but it can. And how does it show? Well, basically, Kaposi sarcoma, if it becomes the disease entity, it can show anywhere. It's usually a skin tumor, and it can show with low CD4 counts, but it is not as many other diseases restricted to the very low. You can see Kaposi sarcoma patients with 300, even 400 cells. That's not rare. The typical finding are these dark spots that you see here. Here it's quite disseminated, quite a lot of dark spots. You can have single spot, 2 spots, 10 spots, 100 spots. And they typically grow, and they typically lead to, they can even get necrotic, and initially they are just a spot in a sense of a macula that you can't feel, but then eventually it can become more and more tumor-like. And here are some other cases, and where you see different different characteristics. One is that it follows these Koebner lines, the tension lines of the skin. So that is one of the characteristics of Kaposi sarcomas. Here you see that one of the areas where it's particularly often found, and it's a key thing to if you investigate or if you assess HIV patients, make sure that you have a look at the groins, because that's the area where Kaposi sarcoma predominantly starts. So in the groins, on the feet, on the legs, and on the palate. So that's the three areas that are really the most important to assess. And I just want to draw your attention, if you are interested in more basic facts on Kaposi sarcoma or on other HIV diseases or on ultrasound, then just remember there is the Lighthouse website, and if you go to Lighthouse resources, then you find the Lighthouse training manuals, and there we have a case manual with tons of Kaposi sarcoma cases. So this is a case which is more difficult, or was more difficult for us, simply because the skin has changed. This is a patient who is obviously suffering from, not from KS only, he was suffering from vitiligo, which is the depigmentation. And then suddenly you see that the tumors, which we know quite well on the dark skin, look quite different, and they look now much more like the Kaposi sarcoma on Caucasian skin. So obviously, when you're not sure, what you do is you take a biopsy. That is not very difficult. You just have a puncher, you do a local anesthesia, you punch it out, you take the sample, and then you put it into histology, and you see this typical fibrocytic cells, which have this fish swarm-like pattern, which is characteristic for Kaposi sarcoma. And if you have immune staining, which we sometimes have, then you can see this is staining in brown cells are shown to be infected by Kaposi sarcoma virus. So it's the direct proof that it is Kaposi sarcoma. Good. It can not only affect the skin. If it was only the skin, ultrasound wouldn't help us very much. But lesions have been reported in practically every organ, including the heart, the CNS, and whatever you think of, you'll find a case report. It's not the most frequent is actually the pulmonary involvement, or at least it's the most frequent that we diagnose, probably because we can do the chest X-ray, and it shows typically this reticulonodular appearance in the lower lobes. It's a typically lower lobe disease, which makes it a little bit different from the TB, which is characteristically an upper lobe disease. It can affect the pericardium, it can affect the pleura, and it can affect lymph nodes, GI tracts, liver, and spleen. So how do we grade it? Well, it's pretty straightforward. Grading T0 is very limited, which is only affecting the skin and not widely, and it has no edema, and it is not a huge tumor, it has no ulcerations, and it is only very flat lesions. And then T1 is anything that is beyond that. And I have to say, I can count on the fingers of one hand the T0s that I saw in Malawi. It's very rare, because most people only seek medical care when the problem gets advanced. And then it is indicated to give chemotherapy. There is a very well-tolerated, we know today, very well-tolerated simple paclitaxel chemotherapy. You give it every 3 weeks. It can be done on an outpatient base. It's not very toxic. It's not, it doesn't have many side effects. So we have quite a good success in suppressing the virus. It is important to remember that, of course, that this paclitaxel is an anti-tumor agent. It reduces the disease, but it does not eliminate the Kaposi sarcoma virus. So you can't, in a way, cure the disease, because what you do is you suppress it to an extent that until the immune system comes up, because you have to start antiretroviral therapy at the same time, then this one clears and controls the disease. And that's, I think, in a nutshell, some facts on Kaposi sarcoma that we need to know to understand where the ultrasound comes in. So what we wanted to, or what triggered us to look at this, as I said in the beginning, was the question: how much is this maybe confounding if we are searching for disseminated TB with a FASH protocol? Do we maybe find things and then it is KS instead of of disseminated tuberculosis. So we prospectively we did a prospectively observational study for the patients who were referred to us for paclitaxel treatment, or who we diagnosed for paclitaxel treatment. We made sure as good as we could that they had no diagnosis of TB, with all the difficulty that poses in a resource limited setting. I think you know all how difficult it is to say, to really make sure that the patient has no TB. And they all underwent an abdominal ultrasound by our trained clinicians. So we had included 30 patients, 22 male, 8 female, and that is typical because Kaposi sarcoma is predominantly a male tumor. I mean, you see it. I think this reflects this quite well. 2/3 male, 1/3 female. That's more or less what I feel we see. Age 39, 29 HIV positive, 1 HIV negative, which is quite possible. So as I told you earlier, that Kaposi sarcoma is also seen in non-HIV infected patients, but much rarer. And the median CD4 count was 192, but again, it went up to some had even 300. So as I said, it's not necessarily tightly connected to very low CD4 cells. What were the ultrasound results? So basically, let's start with the lymph nodes and with the effusions, because that's, of course, where the overlap comes with the TB findings. And the inguinal lymph nodes, 20 patients, so that's 67%, had these swollen lymph nodes, which were seen on ultrasound in their groin. Which, okay, you can say that's not traditionally where we look for the TB ultrasound, well, for the TB lymph nodes, but also when you look 10%, so that's 3, had additionally abdominal lymph nodes. So if we had done just a standard FASH scan, we would have found the abdominal lymph nodes, and somebody might have said, oh, this is TB because there are lymph nodes. Next, on the effusions, and again, we had one patient with a pericardial effusion, so that is again 10%. There is pleural effusion in 6, 20%, and ascites in 4. So these are also can be interpreted as signs of TB. So it's again one has to be careful that we don't mix that. But our conclusion is clearly Kaposi sarcoma findings in ultrasound can cause confusion with TB findings. Well, is that a problem? And in reality, unfortunately, it is, because the clinical picture is very similar. Patients suffer of night sweats, they suffer weight loss, they suffer they suffer fever, and of course pleural pericardial effusion. So it is indeed very common that patients who are referred to us for Kaposi sarcoma treatment actually have TB treatment already, because somebody thought, this must be TB, we start them on treatment. Reality is it shouldn't be a problem, because only 1 to 2% of patients have Kaposi sarcoma without skin lesions. So if you spend the time proper and examine the skin of the patient carefully, then you should find KS, one or the other KS lesion, and that should trigger your questioning whether this is really TB or Kaposi sarcoma. So, but anyway, that we all also know how reality is, and often very careful skin examinations, as easy as they seem, there may be difficulties due to privacy and other reasons. So in the end, it is quite common that our Kaposi sarcoma patients are initially treated for TB. Now let's look at the spleen, and because the spleen is a particularly interesting organ for us in ultrasound, and indeed we found focal spleen lesions in 3, and that's again 10%. But interesting enough, they were different. They were mostly echogenic. So that they are different, and I'll show you in a minute how they differ. And then in 3 patients, we found a quite unusual, that wasn't described before, but we see it relatively frequent today, what we call the sponge pattern or sponge-like pattern of the splenic tissue. So let's start with these echogenic spots. So here you see a spleen, and you can see even with a convex probe, you can see there's a convex probe. Here is the upper side. We can see here that there is a pleural effusion in this patient. And then we see in the spleen, we see this, yeah, 0.5 to 1 centimeter echogenic lesions in the spleen. And if we look with a linear probe, and as I always recommend for the spleen, oops, sorry for that. For the spleen, the linear probe is ideal. You can see these are echogenic tumors. They look like in another patient, I would say this might be a hemangioma, but it's rare that you have so many hemangioma in a spleen. So, but they look very well defined. They are very echogenic. And why are they echogenic? I mean, you have to remember, this is a very vascular and tumor. It's a lot of tiny vessels which also create the appearance in the skin. And these convoluted vessels have a lot of surfaces. They have a lot of interfaces. So they throw a lot of echoes back to the machine. And that's what we see. So we see that there is a lot of these are very interface rich tumors. And that is a typical patient with KS. Now here's another in a very high resolution and very nice to see. So you can see there is a pleural effusion, then you can see the diaphragm muscle here, and then you can see the spleen below. And inside the spleen, you see there is this KS lesion. Unfortunately, it's not pure. All of them were purely echo rich. This is a different patient. You can see here the lesions have changed a little bit. They are more hypoechoic, but they still also have an echogenic center, some of them. And here is another one with a linear, again a better probe. So you see they look a little bit more like it's called the bull's eyes or the target sign. With concentric hypoechoic and then echogenic center. So that is also a pattern that is seen in Kaposi sarcoma. It is not only, again, it's not 100% Kaposi sarcoma. You find that also in other tumor metastases are well described with these bull's eye or target. And so it's not 100% characteristic, but within the clinical picture, it is very typical for KS. Good, and then we come to this sponge spleen, and that is something that I that I want to mention anyway, because it was for a long time, it was a problem for me, because the clinicians found something like this, and then they said, oh, are these microabscesses? So why are they asking? These lesions are very, very tiny, so they are 1 to 2 millimeters, yes, if you measure them. And additionally, they seem to be kind of connected. They seem to even follow a little bit the vasculature. So, and additionally, they are predominantly seen in the superficial area, and they are only seen when you use the linear probe. And we often didn't know, shall we call this TB? Shall we start treatment, or shall we not? And luckily, colleagues from, particularly Francesco, I think you heard him on this series previously, he mentioned that he has the same problem in Italy. And so we started to look at it a little bit more on this sponge pattern and described it a little bit more in detail. And then we realized that these are not microabscesses. These are actually, if you remember the anatomy of the spleen, it has the red pulp where the mainly red erythrocytes are stored, and then it has this white pulp where lymphocytes are functioning as a filter for the blood around it's called the periarterial lymphocyte sheets, pulse. So here you can see these pulse around the vessels, and if you stain them for CD4 and for T cells and for B cells, then you can see that this is the area where actually the lymphocytes are dominantly located. So this is in a way the lymphatic active area, and if for some reason it becomes more visible and more in a way swollen maybe in the patients, and that is what we can see with the linear probe in the ultrasound. And it is actually very rarely described. In children it was seen before, but it was not described in adults before. probably simply because nobody looked so frequently with a linear probe on the spleen. Is it a sign of anything? Well, if here you see, we between us and friends, we collected about 16 cases, and you can see there is a wide spread of underlying diseases. So we found it in lymphomas, we found it in disseminated infections. Yes, indeed, we found it in KS, and we also found it in multicentric Castleman disease, which is another tumor disease which is caused by human herpes virus 8. But also, Francesco had a few patients who had only an HIV infection, and only the HIV infection in itself seemed to be triggering this stimulation of the white pulp. So that is just to remember that this can be associated with KS. What our clinicians do now at Lighthouse is if they find somebody with a sponge pattern, they say, oh, let me look again carefully all the skin for KS. Maybe it wasn't done that thoroughly. And sometimes they find something, well, then it is KS associated, or they don't, then, well, then we have to think of other diseases or other conditions. So now I want to show you a little bit the difference between sponge spleen and microabscesses. And we call them microabscesses, but this is one patient, and indeed you can see there is a sponge spleen, and you can see already there are some lesions which are not so spongy. But if we look a little deeper, you can see there is a sponge component up here with these tiny little lesions. But then these are actually the microabscesses. So they don't look that micro when you compare them to the sponge, but they are just a centimeter, less than a centimeter in diameter. So they are small, but suddenly if you compare them, they look quite impressively big. But this is a patient who has a sponge spleen plus microabscesses, which can obviously happen. And yeah. So I think that's for the sponge spleen. And finally, we want to look at how are we doing on time, half an hour. We want to look at the liver, and that is not so much part of our FASH scan, but still it is interesting. And we found that 6 patients had actually also echogenic lesions in the liver, and again, resembling hemangiomas. And what is also known, or what can also be seen, is these echogenic portal areas, and I'll show you that in a second. So here is a patient again. We see this is with a linear probe, pleural effusion, diaphragm, and then the liver. And inside the liver, there is this subcapsular lesion, and that is in the end here the histological or the pathological equivalent of a Kaposi sarcoma just under the surface of the liver. Of course, this picture is just fitting very, very closely. It is not the same patient because the patient did not die, and luckily we just treated him with paclitaxel. So this is the liver of a different patient, but it is still very, very similar. And here we see the other phenomenon. This is more towards the left liver lobe, and you can see here are some portal triads with a portal vein and the vessels. And then you can see that in that area there is again some hyperechoic infiltrates, and that is reflected here on this pathological specimen, where you can again see that the Kaposi sarcoma likes to infiltrate around the portal tracts, and it makes it a little bit confusing sometimes with schistosomiasis, because that's also causing echogenicity around the portal tracts. But of course, the patient is a completely different patient. Good. Then we have this one here again. This looks very much like the lesions in the spleen. They are just now in the liver. And here's another example of a lesion, of a hemangioma-like lesion in the liver. Good. Another liver lesion, which is here, yes, a little bit more bull-eye. You see that it has the echogenic rim around, and then the black area is the pupil of the bull. So that's the one of the other patterns that can be seen. But again, already you see down here one that is more echogenic area. Good. And here we have, I think this one we can leave, but we can again see that there is some infiltration or some echogenicity around the portal area, which is more marked if you look carefully for it than you would expect it in a normal patient. And with a linear probe, again, lesions close to the vessels. So that is all again and again the same picture. So it's echogenic. Remember, why is it echogenic? It is echogenic because this is one of the properties of ultrasound. It finds interfaces that create echoes, and this is a very interface-rich tumor, and that is what basically causes this appearance. Is not always so. In this patient, we had this is a patient with a very, very advanced Kaposi sarcoma I saw in Zomba Central Hospital, and in this case, again, we see pleural effusion. She had ascites, and additionally, in this case, she had massive infiltrations along. She was not part of the study, but she had massive infiltrations along the portals. But in this case, they seem to be more hypoechoic compared to the rest of the liver. Maybe also due to the fact that the rest of the liver is very echogenic. So in a way, you always, when you do ultrasound, you have to compare in a way to the surrounding. And in this case, the tumor looked less echogenic than the surrounding liver. Can also happen. Good. Rarer findings. This, I remember this girl quite well. She came to us and we felt like she had a cholecystitis because she had really the typical clinical picture of a cholecystitis. But what was strange that she had a little bit of echogenicity and a little bit of changes in the smaller bile ducts. Okay, we thought this could also be a cholangitis. And if you see the gallbladder, it is basically completely filled with solid material. And what was then, again, when we looked at her carefully clinically, and she had a lot of KS lesions on the skin and on the mucosa. And then we said, well, maybe this is nothing for the surgeons, but this is maybe just a manifestation of Kaposi sarcoma in the gallbladder. And obviously we started to treat her with ART and with paclitaxel. And after 2 or 3 cycles, the gallbladder looked completely normal. So this is an infiltration into the gallbladder. And here you see the liver, and then under the liver you see this ring-like, or this cork roundish structure, which is the stomach. But this stomach doesn't look quite normal. You see there is only a small there is the central gas or central air is here, and then the wall looks quite thickened. And that was actually the complaint of this patient, that he couldn't eat and he was always vomiting, and he could only eat very, very small amounts of food. And so we don't have an endoscopy of this gentleman, but this is again a picture of somebody else, and that is what it looks to have a Kaposi sarcoma infiltrating the stomach. And that is, again, it is quite common. So probably it is just that for us it is rare that is so strong that we can see it, but it is a common thing that Kaposi sarcoma infiltrates these mucosal surfaces. Good. With this, I come to an end. I want to see if there are any questions for me. Then this would be a good moment. Is there anything in the chat or something? And we could take it now. Otherwise, we could look at 2, 3 cases to put it in the picture. Over to you, Long.
Yeah, thank you very much, Tom, for very comprehensive and very fascinating presentations. So currently I can't see, so this is a perfect time, as Dr. Heller say. Do you have any question for himself? You can either unmute yourself or you can put it in the chat. And sorry, Tom, just to clarify, you also have a couple of cases that you would like to present on, is that right?
Yeah. I have some two, 3 cases. I just thought to put it in a context.
Yeah. So I think I'll give everyone about 30 seconds to type the questions, and if there's none, then we can just move on to the cases.
I mean, just for me to also bring in a question from my side, do we have people from? I mean, I would expect it to be to be seen in Papua New Guinea or in other in area. Do you see Kaposi sarcomas frequently or rarely or at all? Just for my learning, I'm not a I'm not I haven't worked in the Pacific area, so I don't know. How is that? Is there somebody from Papua New Guinea? Ah,
We have, based on the guest list, we have a few from Solomon Island. I think from definitely one from Papua New Guinea. Um,
well,
Nico.
anyway, we don't want to put them on the spot.
No.
So let's
Yeah. So
see what then I'll just continue with some implications and cases, just a few slides to put you to put it in context. So this is how ultrasound helps us or affects our decision making. That's basically the question. Because I mean, and in the end, all of this is very interesting. I mean, and if you are, and the more you do ultrasound, the more you get excited about ultrasound in itself, because you can see things, and that gives you somehow a pleasure and academic satisfaction to recognize things. But of course, it's predominantly, especially when we think of point of care and POCUS, it should be driven by the question, how do I change my treatment? And I want to look at this patient. Let me see. This is a case of a 34-year-old male. Recently started ART and TB treatment 6 weeks ago. So both ART and TB started at the same time, and TB was suspected because of his intermittent fever, loss of weight, and mild cough and shortness of breath. So makes sense. It's not a very strong indication, but it is enough. Let's say in a patient that I don't remember the CD4 count, it's enough to say presumptively we can start him on TB treatment based on the symptoms. But obviously, the clinician observed that there was no improvement, and then he sent the patient to the lighthouse, and we there because our clinicians are so trained and they just it's a routine thing. They say, let's do an ultrasound, and they find this a pleural effusion, which nicely goes with the TB diagnosis. But when they looked at the spleen, and that's what they do routinely for the FASH, they found this, and quite obviously that are not microabscesses, TB microabscesses, because remember the TB microabscesses are the dark spots, and this is actually these are very white spots. So in a way, it dragged them away from thinking about a TB, and they checked again, and they found they found one lesion on the foot, which was really very non-impressive. And but we took a biopsy, and I mean, it was clinically sufficiently compatible with KS to start treatment, but of course we do biopsies for all of our patients, and then start treatment KS treatment immediately. And then by the time they come for the second cycle, we have the result, and this was a KS. So basically, this is one thing. As I said, the spleen lesions can point you towards KS. So that is certainly for our clinicians by now a very good learning point. Yep. So this is well, this is not from the patient, but these are the lesions, and re-examination. Yeah, the typical skin lesions. Thoracocentesis was performed. Yeah, that is maybe also an important point. I just want to mention that when you drain, I mean, if you find pleural effusions or pericardial effusions or ascites, and you drain them, they very commonly they are blood stained. So that is or let me put it the other way around. If you see a blood stained effusion, think of malignancy and think of KS in an HIV positive patient. So because well, obviously, also TB can, in a low percentage, cause blood-stained effusions, but more commonly it's straw-colored. So if you find a bloody effusion, then that should make you think about KS or in general about malignancy. So the patient was treated and improved over the next weeks. So this is the second case, which is a young girl, which posed a lot of trouble for us, and she still does, because she's not getting completely out of the woods. So she's 19-year-old, HIV positive on ART for 15 years, so infected at time of the birth. And as you can see, from her file, we found her recent viral loads 2 years ago, 3,000 copies, 1 year ago, 16,000 copies, 6 months ago, 250 copies. And when we talked to her, she admitted that, I mean, this is very common with our teenage patients, that they have problems with adherence. Maybe they have a boyfriend or something, and that they go to school, and all that triggers problems. Or, I mean, being a teenager in itself can be a problem enough. So it is a difficult time for taking ARVs. And in this case, she came with a CD449, cryptococcal antigen negative, and urine LAM for TB test negative, but really severe immune suppression. When she was admitted to the main hospital. We saw she was seen with severe shortness of breath, puffy face, dizziness, typical KS lesions. Here you can see some of them. She had more. She had also some at the palate. But what was interesting were her vital signs. She had very low blood pressure, so very high heart rate. So by definition, this is a shock, yeah, because with a heart rate of 137 and a BP of a systolic BP of 90, respiratory rate elevated, not much fever. She was given IV fluids and a lot of oxygen because the saturation also low, and ceftriaxone, because, well, this in a first go, one could say this is likely a septic picture, which makes sense, let's say. When we looked at her FBC, white blood cells not in a high, hemoglobin significantly low, and the platelets also low. So she received blood, which, because this hemoglobin of 5 could also explain her shock. After all that, the situation improved a little bit, but not really very much. I mean, so her blood pressure stabilized, and her saturation stabilized as well. So now what we thought is that this maybe not sepsis, but is this the KS that is simply causing this disease? And of course, that is a big difference, because if you find the KS as the underlying cause, then you would give her chemotherapy. If you say this is the sepsis, then you would say, oh, should I really give her chemotherapy, because it might cause immune suppression? There is always a bit of a hesitancy to give chemotherapy to a patient with an active infection. We suspected that she suffers of something that is KICS, which is not very well known. It's called Kaposi-induced cytokine storm. So it's basically the virus infection causing a systemic inflammatory response, which is characterized by all these vital changes, but also by platelet dropping, and that is, so it fitted. So we said we take the risk and we give a dexamethasone actually and paclitaxel, which is counterintuitive for a sepsis, but we did that. And it also helped us that we did some ultrasound, because, well, there was a pleural effusion, which could be due to KS. There was a pretty significant ascites in the girl, and there was no pericardial effusion. And then there were lymph nodes, particularly on the neck. Actually, we took a biopsy of these because we wanted to make sure that they are indeed also KS, and that we don't have an underlying other disease, but they came out KS. And when we looked at the spleen, we found one echogenic lesion, and I think you've seen that a couple of times now. So again, underlining that we are looking at a case of really disseminated multi-organ infiltration, Kaposi sarcoma. So with this evidence, we treated her for We treated her, and actually she got better. The problem is that after 6 cycles of paclitaxel, she was really well. She after the second, she also already wanted to go back to school, and eventually she did that as well. But when we stopped after the 6th cycle, it took 2 or 3 months until it came back because the CD4 were very slow to come up. So we had to give a few more cycles. And at the moment, we are balancing a little bit of paclitaxel plus plus the antiretroviral to get her immune system to the shape that it can control the Kaposi sarcoma. And the last case is again a patient with advanced HIV disease, 56 cells. Again, cryptococcal antigen and urine TB was negative. He reported loss of weight, night sweats, no cough, so could be TB, could be KS. On a physical examination that revealed some typical spots on his legs, and here you see this infiltration into the gingiva. So this is a typical KS behavior, and our clinical officer did an ultrasound, and what did she find? She found this spleen, and again, I think you got the message now. White spots mean KS. And then she looked with a linear probe, and there was a problem. Because obviously now we see this patient has a sponge spleen, which is fine, which we know it's compatible with KS. It has hyperechoic lesions, white spots, which we know this go with KS. But then she also had a couple of these dark spots, which would normally point us to this is TB. So what we felt to do is we said, well, with the 56 cells, you can indeed have a Kaposi sarcoma and TB, but TB is very frequent. So we treated both. We treated the KS with the paclitaxel. We treated the TB with the rifampicin, with RHZE, and we treated, of course, the HIV. And this is basically 6 weeks later. You can see there are still some spots in the distance, but they are far less now. And if you look with the linear probe, you can see that the sponginess has gone, the microabscesses which we assume is where TB have gone, and the echogenic spots have also overall massively reduced or almost disappeared. So in the end, this is to make life simple. If you see white spot, it's KS. If you see black spots in the spleen, it's TB, which is always nice if medicine is easy. And with this, I like to thank you, give you some clinical pearls. Effusions, enlarged lymph nodes, and lesions in the spleen and liver are seen in disseminated Kaposi sarcoma in HIV patients, and confusion with TB is possible as symptoms and findings overlap. It is luckily that at least the organ lesions are more echogenic and should always raise suspicion and trigger careful re-examination of the whole skin. And findings widely disseminated forms of KS in advanced HIV patients with signs and symptoms of sepsis may be due to a disease entity, Kaposi's inflammatory cytokine syndrome, or Kaposi-induced cytokine storm, or KICS, and that needs urgent treatment. And again, the website for those who want to read more. And with this, I like to thank you and hand over back to Long.
Amazing. Thank you very much, Tom. And I will stop the recording now so that everyone feels free, more relaxed to ask you questions.